Hi everyone, the topic of my presentation is atypical cutaneous ulcerations in an AIDS patient masquerading as disseminated Cryptococcus neoformans. I know that's a lot, but let's get right into it. C. neoformans lives all around the environment, usually in the soil, tree hollows, decaying wood, and bird droppings. It's important to know that the infection is not contagious. Inhalation of microscopic fungus from the environment can cause humans and animals to get the infection. However, most people who breathe in C. neoformans never get sick from it. In people who have weakened immune systems, C. neoformans can stay hidden in the body and cause infection later when the immune system becomes too weak to fight it off. And so in the figure on the right, you can see the damage caused by the fungus at different levels in the body. Infection with Cryptococcus neoformans begins primarily in the lungs, and in immunocompromised patients, it can disseminate to the skin, soft tissue, and/or the central nervous system. The incidence has decreased since the discovery and use of antiretroviral therapy. There are about 2 to 7 cases per 1,000 individuals based on population-based surveillance data in the US, and approximately 220,000 cases per year that result in approximately 181,000 deaths. Although infection through C. neoformans remains rare, the mortality from it remains quite high, particularly in sub-Saharan Africa, followed by Asia and the Pacific. So HIV enters the body by attaching to the CD4 cell, fusing to the cell wall, and releasing the viral capsid. By using its reverse transcriptase enzyme, the virus uses its RNA to create DNA, which then enters the CD4 nucleus. Another enzyme called integrase inserts the HIV DNA into the host, thereby integrating itself into the host primarily. From there, this new integrated HIV DNA uses the host CD4 cell's enzymes to make the mRNA from which HIV proteins are made and assembled at the cell wall. The new virus then assembles and pushes out of the CD4 cell wall and eventually matures. This causes the CD4 cell to eventually swell and die. As the CD4 cell counts drop, the patient becomes more immunocompromised and is susceptible to opportunistic diseases such as Cryptococcus neoformans. This is also why the CD4 cell count is measured in patients with HIV and AIDS in order to monitor the severity of their illness. This brings us to our patient, who is a 61-year-old male with a past medical history of AIDS and bipolar disorder, who presented with a 2-month history of progressive ulcerating skin lesions. He was not taking antiretroviral therapy for his AIDS, and his most recent CD4 count was 16, with an HIV viral load of 2,100,000. On review of systems, he endorsed headaches, cough, dizziness, visual changes, fevers, and chills. Physical exam revealed multiple large angulated tender ulcerations, some with purulent granulation tissue at the base of the patient's back, chest, extremities, and anterior scalp, which you can see on the left here in figure 1. Here's an aerial view, and you can see both the extent of the infection on the anterior scalp as well as the surrounding erythema. Figure 3 shows the variety of skin lesions on the torso of the patient. Figure 4 is one of the most striking images in this presentation, both due to the size and the depth of the penetration of the lesion. Figure 5 is a smaller lesion seen in the right lower extremity. Initially, the patient had been started on broad-spectrum antibiotic therapy for treatment of his skin infection. However, our patient failed to respond to therapy, and so a broad workup was performed. The patient's CBC and CMP both returned within normal limits. Blood and urine cultures were also both negative. During this workup, the serum cryptococcal antigen was positive with a titer of 1 to 1,280. The LP opening pressure was 20 millimeters with normal protein and cell count on CSF studies. The CSF studies were also negative for India ink stain, which is used to visualize the fungus, and also for cryptococcal antigen, even though it was present in the serum. The repeat LP that we performed 4 days later remained essentially unchanged. As you can see, these images highlight both the extent of the cryptococcal infection in our patient and the severity of the manifestation on the skin. In many areas of the body, the level of erosion of the skin was quite deep. Figure 7 is in the right upper extremity near the deltoid. and figure 8 is a lesion in the posterior aspect of the patient's scalp. CT imaging was also performed to assess the extent of infection within the lungs, and CT results showed bilateral hilar, axillary, and lower mediastinal lymphadenopathy with bilateral lower lobe ground glass opacities. What was most surprising to us was that although our patient was extremely immunocompromised, there was still no CNS involvement. And so we found it quite unusual that a patient could develop disseminated cryptococcosis, yet remain clear of it in the central nervous system. Punch biopsies and tissue cultures were performed from the sites of these ulcerating lesions, and both studies grew yeast morphologically consistent with C. neoformans. The patient was started on induction treatment with amphotericin B and flucytosine for disseminated cryptococcosis with gradual improvement of his symptoms and skin lesions. I just wanted to take a moment and highlight the depth of invasion into the skin caused by the fungus here in figure 14. We find this clinical vignette important because it highlights the extent and diversity of skin ulcerations seen in a patient with Cryptococcus neoformans infection and the importance in keeping it in the differential during physical exam of an immunocompromised patient. C. neoformans is a worldwide ubiquitous fungus which presents in immunocompromised patients with a variety of lesions. Cutaneous lesions are highly indicative of disseminated infection and seen in 10 to 15% of patients. Our patient, while having disseminated infection, did not have CNS involvement, which is seen in 65 to 94% of HIV-associated pulmonary cryptococcosis. Additionally, large ulcerating lesions are rare for the classic cutaneous manifestation of C. neoformans. For this reason, we argue that when examining an immunocompromised patient with ulcerating skin lesions, it is critical to keep cryptococcosis in the differential, given its high mortality if left untreated. I would like to thank my attending, Dr. Trammell Velasquez, for supporting me throughout this process and encouraging me to present this case. I wouldn't have been able to do it without her help or without the help of Dr. Carly Dunn, one of the residents that was on the service with us, who provided me with constant feedback and mentorship. Finally, I do want to also thank my patient for allowing and consenting us to use these images and his story to further our medical education. And I want to thank all of you for your time. Here's some of the references that I used. Thanks.